everyone, and thank you for joining us today. We have, I think we're going to have a lot that we can learn from today's lecture, and it is building on what we learned from Dr. Alan Delameter's last lecture, which was part one of this series. But before we get started, I do want to give a thanks to the Kolokotrones family for their support to create this lecture series. We have had several wonderful lectures. Our first initial one, and if I could get my slides to move, that would be great. They're not moving or advancing, but we'll see what we can do. That we have had several really terrific lectures in this series. Our first one was on genetics, and that is available for you to watch if you would like to see it. It's quite interesting, covering most of what we need on a primer on genetics for those of us who care for children with anterior segment dysgenesis. The next series has been focused on quality of life and the psychosocial development of children with visual impairment. And part one, which is also available and has been recorded, you can listen to. It was really a very interesting talk and a lively discussion afterwards, given by Dr. Alan Delameter, who is on today, also as a panelist, and who will be available for question and answers at the end of Dr. Rahi's presentation. Today's presentation will be basically, again, building on what we learned from part one. And it's really the understanding and measuring impact of vision impairment in children and young people. It's going to give us the answers to the questions of why should we be looking at this? How should we be looking at it? Is it something realistic that you can do in your practice? And then I do want to be sure, this has been a recorded presentation, but I do want to be sure that you all know to put questions and answers into the Q&A little button at the bottom. And afterwards, we will have a live discussion. Dr. Rahi is here this morning, and we have a group of our quality of life investigative team on who will be able to chime in and help with investigating this very interesting and actually rarely looked at topic. One other call out, if you were on when before we started the presentation, you saw that the survey is still open for providers who care for children with anterior segment dysgenesis. We want to see how, in addition to looking at quality of life and the patients, parents, the families, the caregivers, we want to know how it is for the providers as well. Another area not commonly looked at, but I think one of great importance. Dr. Rahi is someone who, if you look at this literature at all, her name dominates the field, just dominates it. And she really is an academician. She is an epidemiologist. Her principal role is at the University College of London. She's also a pediatric ophthalmologist who practices at Great Ormond Street Hospital. And this morning, as I mentioned, I think we're all going to get the impact of why we should be doing this and how can we do it as clinicians caring for these children. Once again, this is recorded, but afterwards, please stay on for the live discussion, and please put any questions that you may have in the Q&A little box below, and we'll be watching for it. Okay, and now, Yvette, if I could ask you to key up, let's go.
It's such a pleasure to be taking part in the Kolokotrones lecture. I'm very grateful to Dr. Grajewski and the network for the kind invitation to talk about a long-standing program of research that we've been undertaking to understand and measure the impact of vision impairment on children and young people. And I'm going to be using our program of research as a vehicle for discussing the issues that are relevant in this area and to share with you some of the lessons that we've learned along the way. As you know, this is the second of the two-part lecture for 2021. I've very much enjoyed hearing the first part delivered by Dr. Delameta and the discussions that followed, and I hope that my talk today will complement that discussion and take it in other directions. The research I'm going to talk about is one of a number of different research programs undertaken by the fantastic Vision and Eyes group that I have the privilege of leading, based at UCL and shown here. We are a really broad multidisciplinary group. Our group includes epidemiologists, statisticians, health psychologists, and health economists, and many of us are actually ophthalmic clinicians as well. Our research encompasses both discovery science and translational research, and we aim to inform prevention, diagnosis, and treatment of childhood eye conditions, as well as informing services and policy in this area. So our work really spans the full pathway of translation that's depicted in this slide. As such, we're very pleased to have contributed in a couple of ways to the WGA consensus document on childhood glaucoma. For example, in relation to an epidemiological study based in the UK, some research we've undertaken on the role of perimetry, and of course, to the addendum on patients, parents, and providers as partners. Here are my fantastic colleagues in our group at UCL who have specifically contributed to the research that I will present. And the reason for showing them all to you is to really underline the fact that what I'm presenting to you is very much team science, both in terms of the disciplines that are required to undertake this research and actually the very large number of people in the research group who contribute to this. Of course, none of this research would be possible without the participation of children and young people living with vision impairment and their families, over 700 so far in the research I'm presenting to you. And we very much rely on our clinical collaborators throughout the UK and our multi-professional study advisory group. Of course, none of the research is possible without funding, and we've been very fortunate to receive funding from a number of different funders over the years. So what I'm going to do is take you on the journey of our research programme. I'm going to start by examining why I would put to you that all of us as clinicians should really be interested in capturing and understanding the perspectives of children and young people in relation to the impact of their vision impairment, and specifically the impact in terms of their quality of life and their functioning. And then I'm going to talk you through the how and the issues that you may want to think about in undertaking this journey yourselves. So starting with the why. The first reason I would suggest that we should all be interested in this area is because health, according to the WHO, as shown here, is a state of physical, mental, and social well-being. So arguably, as health professionals, we all have a responsibility to pay attention to all three aspects of health. Again, drawing on the WHO's work, we see here their definition of quality of life. The key thing is that it's defined as the individual's own perception of their position in life in the context of the culture and value systems in which they live and in relation to their own goals, expectations, standards, and concerns. So in a nutshell, quality of life is complex, it's multidimensional, and it's subjective. Our interest as health professionals is in health-related quality of life, And that's just one aspect and one domain of quality of life that we can measure. The second reason I'd like to suggest that health professionals should be interested in assessing the perspectives of their patients is that ultimately we all aim to provide the best possible healthcare. This slide shows the 6 dimensions of quality in healthcare that are internationally acknowledged. And I'm sure that you'll agree that if we look at these dimensions, namely safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity, that we can see how capturing the perspectives of our patients become a really important part of the assessment of each dimension. Or perhaps put more succinctly by Professor Berwick, who I'm sure you will know is as an international leader in healthcare improvement, in a quote from some decades ago, probably the ultimate measure by which to judge the quality of medical effort is whether it helps patients and their families as they see it. The third reason for being interested in patients' perspectives is that in almost all healthcare systems around the world now, there is a movement to put patients at the centre of policy and innovation. This slide shows some of the recent policy documents in the UK. Similar policies exist elsewhere. So for us now in the UK, it is explicit within the NHS that we need to understand and meet the specific needs of children, young people and families, and that routine use of what are now called patient-reported outcome measures, or PROMs, and patient-reported experience measures, or PREMs, is a particularly important way of achieving this. The fourth reason for wanting to understand our patients' perspectives of the impact of their eye condition is that it makes us better clinicians. There's really now quite an extensive body of literature showing the significant benefits of using patient-reported outcome measures, or indeed patient-reported experience measures, in routine clinical practice. But I've chosen here to highlight the conclusions of a recent review that helps us to understand how this benefit is realised. It describes the findings of their realist synthesis of the body of literature that exists as showing that PROMs completion is not a neutral act of information retrieval. Completing PROMs can actually change how patients think about their condition. The ways in which clinicians use PROMs is very much shaped by their relationships with patients and linked to their professional roles and what they perceive as the boundaries of those. POMS completion and feedback shapes and is influenced by the process of building relationships with patients, rather than just their impact on information exchange and decision-making. So this is more than just handing over some form of instrument and looking at scores that you come back. This is an active part of your relationship and your responsibility as a clinician. So asking our patients about the impact of their condition and any treatment or other management that we provide to them for this changes both our understanding as clinicians, but also our relationship with our patients. And having spent more than 15 years doing research in this area, I now know that I ask better questions of my patients, and therefore I learn more from their answers than I used to. And just to illustrate this, I've put here some quotes for some of the children and young people who've participated in our research to really illustrate what might be going on in the minds of our young patients when we communicate with them in our usual ways. I particularly like the quote that says, "I say I've got a blob in the middle of my vision and they say blurry eyesight, which is not what I've got at all." Finally, as we all know, vision really matters, It's fundamental to how we learn about ourselves and other people and the environment around us. As Aristotle observed, sight, most of all the senses, makes us know and brings to light many differences between things. So vision impairment is bound to affect all aspects of the life of an affected child, for example, through its impact on psychosocial development, on language, on neurobiological processing, or on cognition. And Dr. Delameter covered some of this in his talk earlier. Indeed, my paediatrician colleagues in neurodisability at Great Ormond Street, where I practice clinically as an ophthalmologist, talk of vision impairment as a developmental emergency. And of course, vision impairment starting in childhood casts a shadow across the whole life course. As demonstrated here, showing some of the research we've undertaken using the UK Biobank study of over 500,000 adults, which shows that even mildly impaired vision in one eye can be associated with adverse general health and mental health outcomes, and demonstrating the gradient that you might expect of increasing severity of outcomes by increasing severity of vision impairment. And finally here, in thinking about this lifelong impact of childhood vision impairment, it's good to remember that the global population of affected children is really quite large, comprises around 25 million children living with severe vision impairment or blindness, and a further 46 million with less severe levels of impairment. So it shouldn't be a surprise, as Dr. Delameter described in his talk, that we do now have a growing body of evidence about the impact of specific eye conditions on all aspects of children's functioning, but particularly on their health-related quality of life. Now, this slide shows the findings of one of our own studies more than 2 decades ago, demonstrating the significantly impaired health-related quality of life of children with congenital cataract. And in this study, we used the generic PEDSQL instrument because that was what was available at the time, but recognized its limitations in fully capturing the specific impact of ophthalmic disease. And here's another one of our studies from some years ago, demonstrating again the significant impact on both children and their families of living with an untreatable, often progressive, and frequently ultimately blinding eye condition. We also highlighted the importance of support for these patients and how this could be targeted by using quality of life instruments routinely. And we commented on the value that quality of life instruments would have as outcome measures in future clinical trials of novel therapies for hereditary retinal disorders. So I hope I've set out some compelling reasons for why, and now I'm going to move on to talking about the how and sharing our research program and the lessons that we've learned from it. And it's really important to recognize that what you should anticipate in this process when you embark on it is not traveling full speed ahead on an empty road, as shown on the left of this screen, but this experience is more like navigating the complex maze shown on the right. At the center of our research program, there are 2 questions. Firstly, what does it really mean to be a visually impaired child or young person? And secondly, what are the real life impacts of the health interventions that we provide as health professionals, but also the educational and social interventions that colleagues outside health provide? The first phase of this research program has involved developing and implementing instruments to measure 2 distinct but complementary concepts, namely vision-related quality of life and functional vision, with these instruments being intended to be useful in routine clinical practice as well as in research. And the second stage of our research programme involves investigating the factors that shape good quality of life and the development of resilience in order to start to develop interventions to support maximising quality of life and resilience. In the absence of any conceptual framework for this sort of research, we started at the beginning by really thinking about what is almost a philosophical question, and that is, who is a visually impaired child? We decided that the most useful framework to adopt would be the WHO's International Classification of Functioning, Disability and Health, which is depicted here. And this schematic shows the relationship between the health condition at the top of the slide. In this case, we'd be thinking about a specific eye condition or all-cause vision impairment. And then we go on to think about how it affects or impacts on bodily functions and structures, or on activities that the affected individual would be interested in undertaking. And finally, on their ability to participate more broadly in society. These three domains, of course, are also influenced by personal factors such as socioeconomic status and the broader environmental factors in the society in which they live. Now, it's possible to have patient-reported outcome measures that assess bodily functions, activities, or participation, but it's important to remember that these are distinct domains in this ICF framework. So this is the framework that we came up with, drawing on the ICF, in which we draw a distinction between how the child functions in real life, that is functional vision, depicted here in blue at the bottom of the slide, and the socio-emotional consequences of vision impairment for the child, that is their vision-related quality of life, depicted in red, and that both of these are distinct from visual functions measured objectively by the clinical tests that we routinely undertake. So we tracked that through, and we were interested in developing two distinct, although, as I've shown you, complementary instruments to assess vision-related quality of life and functional vision that we hoped could sit alongside clinical assessments of visual function. So here's the definition of quality of life that we adopted. And in essence, what we're trying to measure is the gap between the hopes and expectations of the individual and the reality of their life at any given time. Importantly, this is something that only the affected individual can assess and report on. By functional vision, we meant the ability to perform an activity for which vision is required. In simple terms, then, we were aiming for an instrument that would assess vision-related quality of life, which would contain questions that were about how the person thought or felt, and then an instrument that assessed functional vision that would ask questions about how easy or difficult it was to do something. From the outset, we were very conscious of paying attention to the disability paradox. Essentially, why a child with very poor vision in both eyes might self-rate their quality of life as excellent, and conversely, why a child with only mildly impaired vision in one eye might rate their quality of life as poor. Ultimately, this is about remembering that quality of life is the gap between the aspirations and hopes as opposed to the reality of the life of an individual as assessed by the affected person themselves. So more on this. If we take the child at the top of this slide, who lives effectively in a non-sighted world and has done so from birth, she may perceive less of a gap between what she aspires to and what she's experiencing, because her expectations may well be very different to the child shown on the bottom of the slide, who may well have almost normal vision in both eyes, but is unable to process that as well as his normally sighted peers. Unfortunately, this well-established concept is largely unreported in the ophthalmic literature on PROMs. It's received remarkably little attention. And as a result of this, there are many instruments that conflate the two concepts of quality of life and functional vision within a single instrument. This would mean that in a single questionnaire, there might be some questions that asks about how someone feels and some questions that ask about how difficult someone finds it to do a particular activity. In that scenario, it's possible for one child to score high on the quality of life questions and low on the function questions, whereas another might score in the opposite way, which means that both would end up with the same summary score. Clearly, this would be unhelpful because the instrument hasn't provided any real insights into the individual, nor an ability to understand the differences between individuals. Equally, it means that changing scores over time could be missed by a summary score that doesn't change. In undertaking the research, we were also acutely mindful of the need for the instruments to be developmentally sensitive and able to be used longitudinally across the life course. Clearly, the specifics of what matters most to a 7-year-old will not necessarily be the same when he or she is 17 years old, but we would be interested in tracking the impact of the vision impairment and any treatment we provide for it across their childhood. And this is just the same interest as we have when we are mindful of age and development in our clinical assessments. For example, the way we test acuity across the life course. Finally, we were very aware of the really extensive literature in paediatrics and child health in this area, particularly on how inappropriate it is to use measures designed for adults with children. And secondly, the perils of replacing self-reporting by children and young people themselves with reporting by proxies, whether that's parents or health professionals. Both of these also remain areas that many ophthalmic instruments developed for children haven't really properly addressed. So we started, as one does, any programme of research, by undertaking a solid literature review, and I've shown that here. And our conclusions were that despite a surge in the development of measures for adults that could assess the impact of vision impairment, there had been, up to 2015 at least, when we published this review, a lack of theoretically sound, developmentally appropriate, psychometrically robust, validated vision PROMs for children. So with our theoretical framework established, and conscious of the established literature in paediatrics and child health, we undertook instrument development following the classical phases of item development, followed by operationalization, piloting, and then validation in a large representative sample. This foundation stage research was with children and young people aged 10 to 15 years who, from any condition, were visually impaired, severely visually impaired, or blind, using the WHO criteria, but who didn't have any other impairments or disabilities that would prevent them being able to both self-assess and self-report independently. We reported our child-centred approach, in which we drew only on children and young people themselves to identify the issues of interest. And we analysed what we heard from our participants about what it really meant to live with vision impairment by identifying broad themes that are shown here. You can see the issues that we pulled through into the functional vision questionnaire, as opposed to the issues that we pulled through to the vision-related quality of life questionnaire. Our child-centred approach included using verbatim statements for the items or questions in each instrument, as shown here. And here's an example of the qualitative analysis of interviews with a number of participants, which then led to a single item or question, in this case relating to bullying in the vision-related quality of life instrument. Operationalization, that is turning a list of questions into a pilot instrument, was also undertaken only with children and young people themselves, as was piloting and the final validation. So at no point did we seek issues or opinions really from parents or health professionals. This was entirely a child-centred approach. And this work resulted in our 2 foundation or prototype instruments suitable for 10 to 15-year-olds. And it was from that foundation that we then undertook the work to adapt and extend the instruments so that they would be applicable to a broader age range of children and young people. This work was undertaken again following the same established processes of item development, operationalization, piloting and validation, with the first stage comprising talking about the existing instruments to firstly a sample of 6 to 9-year-olds and independently to a sample of 16 to 18-year-olds, in order to identify how well the content of the existing instruments represented the lives of children or young people in these 2 new age groups. We identified substantial overlap between the issues that were relevant to 10 to 15-year-olds and those relevant to 16 to 19-year-olds, although there was some variation in the emphasis or in the frequency of the issues, rather than actually the specific nature of the issue. But we also identified some new age-related issues, for example, relating to independence. Equally, we found a few items were not appropriate for the youngest age group or required some amendments to the phrasing to make them suitable. We undertook rash analysis to assess the psychometric properties of the instruments. And we also undertook a specific calibration of each age group specific version of each of the 2 instruments, using both the core items and the age specific items, which meant that we could develop a scoring system that allowed the 2 age versions of each instrument to be comparable in terms of measurement. So put simply, this means that as a child grows older, the child version of each instrument can be replaced by the young person version, but the scores can be compared and tracked over time. So we now have a child and a young person version of each instrument, and this slide shows you the number of items or questions in each of those. And these instruments are available free of charge from the UCL licensing portal. The links are provided on this slide, and I can certainly circulate those after this session. And indeed, the instruments are actually already quite widely in use internationally by health vision habilitation and educational specialists in their routine practice, as well as being in use as outcome measures in a number of longitudinal studies and in some randomized controlled trials of novel treatments. And some really exciting news hot off the press is that we're delighted to be part of a major collaborative grant awarded to a team comprising some members of the ERNI network that's led by Professor Hélène Dollfuss. This will support a new study which will involve firstly translating our instruments and then undertaking the important piece of work that is cross-cultural validation, that is checking that the instruments have meaning for the new population that we're proposing to use them in. And then these new instruments will be applied in a multinational European study of the impact of hereditary retinal dystrophies. And this work will then provide a validated series of instruments in different languages that can be used in multinational novel therapy trials. And we've also started thinking about digitizing the instruments as an app. We've done some work with collaborators in computer science at UCL. And we have an early prototype which has some good functionality. And obviously, ultimately, we're hoping to continue this work as we think it will improve the way children and young people experience the completion of our PROMs, that it will allow patients to complete PROMs at either pre-specified time points where we invite them to do so, or it will allow them to complete the PROMs when they feel it's appropriate to update us. And in this way, we'll be able to provide in a more continuous way information to clinicians about their patients and how things are changing for them over time. Aside from developing the instruments, we've learned some important other lessons that I'd like to share with you. Firstly, that there are undoubtedly barriers to participation in this sort of research for children and families who are from socioeconomically deprived or ethnic minority groups. We think it's essential, therefore, that any instrument development reports on representation and bias in the samples. And if you read the papers reporting child vision PROMs carefully, you'll find that that happens actually rather rarely. We think this is important because the failure to recognise the silent voices in this sort of research has implications for the use of these instruments in providing equitable and appropriate services for the whole population of children with vision impairment. Secondly, we've now twice shown that children and young people and their parents can differ hugely in their assessment of quality of life and functional vision. These differences are not generally at random in parent-child pairs. So it really matters that children are always heard from themselves, wherever that is possible. But we do think that there is value in seeking the perspective of parents independently in addition, in order that one is able to take an overall view and a comprehensive assessment of both the child and the family in order to tailor interventions appropriately. Now, we drew together some of the other lessons that we'd learned in this paper, which sets out why and how one size doesn't fit all when it comes to child vision PROMs. Firstly, we reiterated the perils of conflating theoretically distinct constructs and outcomes, in particular, conflating quality of life and functional vision. Secondly, we talked about how critical it was to have a developmentally appropriate and child-centered approach to designing these PROMs. Thirdly, We discussed the adaptations that are required to questionnaire format and administration to account for different levels of vision impairment in the population that we're working with. Fourthly, the limits of feasibility of self-reporting by the youngest children. And finally, the critical importance of having a representative sample of participants at every stage of instrument development. In summary, we concluded that whilst we really do need vision PROMs in paediatric ophthalmology, we also have to be mindful of the significant challenges in developing and applying appropriate measures. Our most recent research in this area has been a study examining the feasibility and optimal approaches to using child vision PROMs routinely in paediatric ophthalmology practice, with a second aim being to understand the benefits that accrue from this routine use, with these benefits being those that are viewed as benefits by children and young people themselves, as well as by healthcare teams. And what we've learned from this research is that clinicians actually have quite limited experience of using PROMs, even in the UK, where this is mandated in some areas within our NHS. But they do have high confidence in the potential positive impact on communication with patients, on their ability to take a holistic approach to monitoring chronic conditions, and the value to clinical decision making. We've identified a number of operational issues, such as the collection and analysis of data, and the impact in terms of the time taken to interpret and apply the data in routine clinical practice, as two key areas to think about in planning implementation into routine practice. As you'd expect, training and information before implementation are key, and the benefits of using digital or electronic data capture ahead of a consultation as the most efficient means of allowing an automated analysis and presentation in an appropriate visual format alongside clinical data is really the key to meaningful use. What we learned from the children and young people who participated in this study was that it's really best to try and get the PROMs completed at home rather than when they attend a hospital appointment, if you want to get the most complete, high quality data. And secondly, somewhat surprisingly, those participating in our study didn't really have a preference for the format for the PROM. We offered them a traditional hard copy to be completed with a pen or pencil, appropriately enlarged where necessary, but we also provided them a link to be able to complete this as an online form. And for those attending the hospital, we presented it on a tablet. And really, overall, there was no striking preference, which came as a surprise to us. But we did find that those who completed the PROMs at home, which appears to be the best way of getting a complete data set, in fact, tended to prefer completing the PROMs as a hard copy, despite their impaired vision. And finally, we've been able to demonstrate from this research that self-rated vision-related quality of life and functional vision are not readily predicted from either sociodemographic or, importantly, the clinical characteristics of the individual, in particular, the clinical data that ophthalmologists generally measure or record. And it's for this very reason that the use of PROMs in routine clinical practice can offer important insights, both into measures of effectiveness of interventions, as well as broadening the clinician's understanding of the lives of their patients. This paper also provides some reference values in an independent, large representative sample, which we think will aid interpretation of the scores from the two PROMs that we've developed in both research and in clinical practice routinely. Finally, we've got a fantastic PhD student, Anna Shemrov, who's recently started an exciting investigation that's going to identify factors that shape vision-related quality of life and the development of resilience, with a view to trying to identify modifiable factors or events and/or critical time periods for intervention that will promote better quality of life. And of course, we'll be delighted to tell you more about all of that in a couple of years' time. So I'm going to end on that positive forward view. Thank you so much for listening, and I'm really looking forward to the discussion that we're about to have. Thank you.
Now, if we could go to our question and answers and see what we have. Please feel free now to send in your questions. We're going to have an open discussion. But before we do, I want to give our audience a little introduction of those people who are here today live to help discuss this interesting topic. One is obviously Dr. Rahi, who joins us this morning, and Anna Shemrov, who is the graduate student who is working with her now, has joined us. Our part one speaker from the last session on patients, parents, and providers, Dr. Alan De La Meter, who is here at the University of Miami. Joining us also is my partner and colleague, Dr. Elena Bitrion, who is a glaucoma specialist who is specialty trained in pediatric glaucoma as well. And then we have some, let me see here, sort of a blank. We have also joining us this morning some of our fellows who are working on this topic. Danielle McLaughlin, who is here this morning. She's one of what we call our SOAR fellows, Student Outreach and Research Fellows, who's here for a year to work on specific topics. And this is one that has captured her interest, and I'm thrilled about that. Honch Munchi, she is our co-director of the SOAR Fellowship, and she joins us this morning. The program manager, Anthony Broad, is here, and CGRN's communication coordinator, Yvette Vale, is here as well. So why don't we go to the full screen, Yvette, if you want, and let's open it up for some questions from the panel, as well as from our audience. I think we're gonna, it was interesting. We asked that you all type in the little question box, and we have a few, but I was also receiving some as text messages, which I found interesting as well. So looking at these, Dr. Rahi, would you can see the questions that are basically along a certain theme. If you would like to address those regarding the subjective nature and our lack of experience really with the tools that you have been using and that people use elsewhere as well for quality of life, and that it is really, you mentioned there is some difficulty in the UK where it's demanded. You can imagine here, there is very little to no experience at all. And I think people who have probably joined us from other places may have limited experience as well. Can you comment on those, please, and some of the questions that are there?
Great, thank you very much. And it's fantastic to have these really, really great questions coming through on chat. I'm going to try and channel all of those. So the first thing to say is that although we have a landscape in the UK where problems have been put at the centre of policy, that doesn't mean it's straightforward, and it isn't happening in all areas. So at the moment, the data that are being collected routinely nationally use a very short instrument. It's the EDQ5, which is a 5-item questionnaire that might not be entirely quality of life. It's called that, but it's got some elements to it. And essentially, they're only being collected routinely in adults having our most common surgical procedures, so hip replacement as an example. But there is definitely an understanding of the power and value of these. And one of the areas that's really exciting now is that people are increasingly using routinely collected clinical data, whether that's the old paper and pen records that we all grew up with some years ago, or electronic medical records. And one of the really exciting things that, making routine capture of PROMs a standard practice is that when you want to do what is increasingly happening, applying data science approaches, so that you kind of simulate a randomized controlled trial using existing clinical data. So for very many clinical areas, people are beginning to realize that we have a lot of data that we collect anyway routinely on patients. New trials are very difficult to do, and actually you can start to apply data science approaches. So this is not straightforward to do. Doing it as a clinician, as I've commented in the lecture, it changes your relationship with the patient, and you need to be ready for that. And actually one of the questions picks up on that, so I'll come back to that. But I think really what we need to do, and particularly if you're starting new to do this, I think it's really helpful to look at the lessons learned, because a lot of mistakes have been made along the way. So in some ways, it's an advantage to not be doing it yet, because you can learn, the lessons of the early adopters and the problems that they encountered. And so I think there are questions to ask about why you're doing this, exactly how you're going to do it, which is both the instruments that you're going to use, and actually whether you're going to do this routinely, how that works with your data capture in your clinical practice. How is that going to be most meaningful for you as a clinician, but also easiest and most meaningful for the patient? So why would they do what is now, the buzz term is patient-generated data in epidemiology and other areas of work. This is an example of patient-generated data. And then really, as ever, if you're going to ask something, what are you going to do with the information? So I think the analogy that I would draw is that, as clinicians, we get very excited, particularly in a surgical discipline as ophthalmology is, with any new tech, anything that's bright and shiny. But we do still ask ourselves, gosh, if this is a new way of checking, we've got a number of glaucoma specialists here, intraocular pressure, it's a new way of imaging the optic disc, it's a new way of understanding some aspect of electrophysiology. We are used to asking ourselves, does it work? What's the evidence it works? What is it really telling me? And what is it really adding? So I think that kind of, if I can just segue, if you're happy, Alana, for me to carry on, if I just segue into some of the questions. So the first questions were about generic versus specific quality of life. So the issue about generic quality of life is that if you use an instrument, and many people in North America will be familiar with the PED-squal, but there are other generic instruments. That means you can understand what the generic quality of life is. And you can, for example, compare a child with retinoblastoma to a child with another pediatric cancer that's not an eye cancer. But what you're losing is the specific information that you might want to understand that relates to their vision. So it's not an either or. In some situations, you might want to do both. But if you want something that's really sensitive and specific to vision, then you'll need some sort of instrument that measures vision. The first question from Dr. Patel, I think, also asked then about, if these are instruments that are in English, and as I mentioned in the talk, we are very excited about the fact they're going to be put into other language versions. These will be European language versions. Absolutely spot on. Instruments have to have meaning for the population that you're going to use them in, and that means they have to be developed with that population. But the process that we're adopting, and is the common process, is that you test that. So first of all, you translate it into the relevant language so that you can then go to participants and say, does this have meaning for you? What's missing? What's not relevant to you? And then you adapt the instruments in that way. That's generally a quicker way to get to robust instruments than starting from scratch, because starting from scratch is a lot of work. I'm not saying it shouldn't be done, but sometimes it's better to think, well, we've got good enough instruments that allow us to start exploring what we're missing, what we need to change. And then what you do is you go through the same process of psychometric analysis. So you adjust the instruments, you might put in new items, but you test them and you develop them in the same way so that you have a robust instrument at the end of it. I think that answers the questions for Dr. Patel, which were the first questions.
You know, one of the things that surprised me in the presentation was that when asked, or when you looked at it too, was that it mattered how the person finished it and whether they finished it at home or at the clinic. And, you know, I do have any, or Alan, do you have any idea why children would prefer to do this at home versus in the clinic? Is it something obvious to somebody who looks at this all the time? Because to me, I would have thought they would have preferred a tablet in the clinic rather than, oh my gosh, it's like homework and doing it at home on a piece of paper.
Let me take a stab at that. First, I wanted to say, Dr. Rahi, what a fantastic talk. And I think that you really covered the territory. And as for asking or providing a good answer for the question, why should we do this? Wow, I think you really have given us great rationale, particularly the whole idea of a holistic approach to these patients and how important it is really to assess their experience and their needs as part of a total treatment approach. And you've also provided us a lot on the how. Particularly this question that Dr. Grajewski is just raising about how you get this into routine clinical practice. And I'm so glad that you're really focused on that issue. Your work with, sending them a link that they could do ahead of time, that when they complete it, it goes right into the EHR. Now that's the ideal, I think. We're starting to do some of that not in our vision clinics, but for example, in our pediatric clinic, that's what we do. Or we give them a tablet when they come to clinic. Of course, COVID has upset all of that. So we've done much more. But I thought, one of the things I so appreciate, and I hope that the entire group of listeners will appreciate, is to develop a scale is not an easy process. And it's very complex and but your work is so systematic and took us all through the steps. So I hope nobody thinks that they can just throw a few items together and call it a scale, because a lot more is truly involved in that. But I also thought it was so interesting that your data so far suggests that clinical data does not predict quality of life at all. And that is another reason why it's so important for us to really consider the patient perspective. So thank you so much. Terrific presentation today.
Thank you so much. Shall I expand on this preference?
Sure, go ahead.
So of course, it was a surprise to us as well. So what we found, so we grouped people into two groups. So we randomized them into whether they were going to complete them at clinic or whether they were going to do them at home. And it's amongst the ones who did it at home who actually just filled in, in many cases, a large print version of the questionnaire. Now, so that's a surprise. It's actually been something relatively consistent throughout the development of these instruments. Now, clearly, children who've got no sight at all will need to do it by another means. But it has been interesting that they have preferred to do that. So it's something we have to take into account when you start to think about developing apps, because if you want to routinely capture the data into electronic patient records, you're going to have to persuade them to do it through an electronic medium. So it is a surprise. And we did a couple of things, actually. We looked at how long they took to complete the items, the questionnaires online, so you can see how long it takes. And that's quite interesting because you can see people pausing over certain questions, being quite quick with other questions and so on. My sense is that maybe, despite the impact of the vision impairment, this is something where if you've got to spend a little bit of time thinking, it might still be easier for these kids to do this, as pen and paper, where they've got thinking time, not, looking at a screen and feeling, if you like, a sort of a rush to get it done in a way that, that they might do. Certainly when they did the tablet in the clinic, they were very quick at completing the items. But I suspect that's something about feeling a sense of, I'm here for a clinic appointment, I might be called any minute. or I've got to finish it if I haven't finished it afterwards, and so on. So I think, you know, our sense was we got more complete data sets as well, which meant that I think people had had enough time to think about things. That didn't mean they took hours to complete it, but they could go at their own pace. And I think it's possible that perhaps doing it on screen creates a different sense of pressure for completion and less reflection time.
You know, there's one other aspect of this too, in completing measures that assess patient experience, really looking at the psychological level of their quality of life, their experience. It really requires a standardized environment to some degree. If they're at home, the TV's on, the siblings are fighting, there's all kind of uncontrolled things that could interrupt this, or mom's looking over the kid's shoulder. And so, you know, the privacy needs, confidential needs are also important considerations. And so that would argue for, you know, at least if it is done prior to clinic visit or at clinic visit initially, then that could be seamlessly brought into the encounter, the clinical encounter, because there's a little bit more control over that, perhaps, as a standardized situation. I just wanted to mention one other thing before you. There was a question I thought was quite interesting in the chat or in the Q&A about caregiver burden effects on patient quality of life. I wonder if you could address that.
I will do. And actually, I might bring Anna a little bit into this, but just a very quick response, Dr. Telemet. Controlling it, you know, sometimes we have to accept that families are messy. And if someone's reporting on quality of life, you know, we want the child to do it, but, you know, there may be a parent sitting in the background saying, is that what you really think? But actually, that probably is the same every time they complete that instrument. And remembering that this is a subjective assessment, maybe that's okay. So I'm just kind of, you know, offering the view that sometimes, you know, children are children in the context of a family, and that may be how we collect the data from them. In terms of the caregiver burden and the impact on the quality of life of the child. So actually, this is an area that needs more attention. And clearly, any child's psychological well-being is influenced, and we have literature outside ophthalmology, and you will know that better than I do, about the two-way street, that is, what it means to be the parent of a child with a significant chronic condition or a disability, and what your own, as a parent, your own mental health, well-being, or general health impacts in terms of how you parent, how you respond to that particular child. So absolutely a relationship. In terms of a direct impact on the quality of life, various ways in which the way a parent is feeling would potentially impact on the quality of life of the children. And I think it comes back, it's really the kind of genesis of this entire research program, is sitting as a clinician, you know, in a clinic where you see two families come into your clinic room, one after another, same condition, same level of vision impairment. There's one child that's flying and another child that isn't. And there's a whole package of explanation around that. And inevitably the parents' own quality of life, their own mental health, their own physical, health will have an impact on that. And indeed, this is exactly what Anna is working on in her PhD, to understand the relationship between those two.
I know that we're almost out. Dr. Grudzinski, do you think that we can continue a few more minutes given the questions that are coming in and the
I think so, and I think we've hit on some of the things that I find, you know, very important. And in fact, you know, which is why the series is patients, parents, and providers. And providers not only being caregivers, but providers being the physicians as well. You know, I would ask Dr. Bitrion if she's had this experience where a lot of times the children or the parents don't want to disappoint the doctor. They see how hard we're working to help the child. And so I think filling those things out near us is kind of filling it out near a parent as well. Elena, do you agree?
Absolutely. That's one of the layers of complexity that we see in the clinics. And that's, I think we've been dealing with the clinical severity of the glaucoma, of the disease itself, and on all those things. And we do see different interactions between the providers. We see both spectrums, the ones that are really like helicopter parents, overprotective and trying to protect the children. And we see the other ones that they just feel frustrated, and that's the way that they cannot handle and express what their feelings, which are very valid as well. So I think it's definitely a new territory to explore, and we have a long round to do in a clinical practice, in the day-to-day practice.
It really requires a transformation of the clinical practice. And I think that Dr. Rahi's work now, I gather, is really looking at the utility of this in the clinical practice. And I know there was one of the questions in the Q&A about that. Should we start, are we there yet? Should we start doing this routinely? And you know, I think the question is, one has to, not to be too punny, one has to visualize the practice. How is the practice going to unfold? How can you manage this? What do you do when a patient reports terrible things happening, big impacts, and they may be suicidal or having those thoughts? How do you handle those situations? So this all must be considered. And I would just encourage all of you pediatric ophthalmologists to, and I think that Dr. Rahi is a real leader in doing this, is emphasizing the importance of the holistic care of the patient. You are in a unique position to be able to attend to these issues and to get kids the care that they need. So building a referral network, or even co-locating psychologists and other behavioral health specialists in the clinical, as part of a clinical team, would be one way to approach it. I wonder, Dr. Rahi, in London, do you have that capacity?
Yes. So thank you for that. And I think this is where think very carefully about how you're going to meet the need, because ultimately this is about asking questions that identify need that need to meet. So the question's often asked, what will then happen if you get a quality of life questionnaire that identifies very, very poor quality of life? Obviously, we identified that doing the research. So in a research setting, you have very careful, as you know, through your regulatory approvals and ethics approvals, a duty of care in terms of notifying, in our case, in the NHS context in the UK, the family doctor, the general practitioner, and then offering what are freely available at that, sources to at least get the family and the child involved some help, and then making sure that the family doctor, because in our healthcare system, that's the first point of call. In terms of finding that, though, so what I would put to people is, if you ask the right questions of your patients without using one of these instruments, you'll still hear that if you're listening carefully. So in many ways, this is not changing what you could be asking. I might argue should be knowing, at least if you're not asking about it. It's just a more systematic way of getting to it. So I think would be my first response. And yes, certainly in the UK, although our child and adolescent mental health services are not what they should be, there's a real concern. And actually the COVID pandemic, as you can imagine, has really thrown that into a very sharp relief, is that people do struggle with getting access. We do have access that's available because we have a publicly funded healthcare system. So there are services that are available. They're not always easy to get through to. The other thing I'd say is very often, as we were doing the research, patients would say, no one's ever asked me this before. You're asking me really, really hard questions, and my life is tough, and thank you for asking. And it always used to amuse me that at various stages when we used to go to ethics committees, to approve the next stage of the research, they'd say, I remember very clearly being told, well, you can't possibly ask these children if they're being bullied, and we'd say, but they're telling us they're being bullied. So the idea that you think we shouldn't ask that because it might be distressing when that is their lived experience, it was kind of missing the point of what this process is supposed to be about. So it's not easy, and it needs thought, as Dr. Delameta said. But actually, it's just formalizing what I think a lot of us do as clinicians already. We know that their lives are complicated and challenging, and we're just trying to see what we can contribute to help.
But I do think it's a deeper dive than what we do in the clinics normally, at least my experience here. I mean, we went through the why and the how, it's the who should be doing this. should it be us? I mean, we mentioned pediatric ophthalmologists and they're used to dealing with children. A lot of our group, anterior segment dysgenesis and glaucoma, they're adult trained glaucoma specialists, and they're looking, and they feel uncomfortable, honestly, in asking these questions. And there is an element, at least here, and maybe this is one of these cultural elements that I don't know of, where the family wants to behave like, yeah, we're all doing great, and all that. There's this bravado that if I were to say, are you, or how's it going? It's, oh, great, wonderful, we're doing, and they want to prove what great parents they are, or the child wants to prove in front of the parents or to the doctor, as Elena was saying, there is that expectation where they want to make us happy as well, that they may not be answering completely honestly. I love the idea of them. I love hearing that we have a reason to have them do it at home. Where, that was great. But Lauren Bleeden's question about, are we there yet, is a really, that's a real question. Should we here start using these tools? Should we start putting this into our practice now? And if so, we'll deal with that kind of the logistics of, do we give it to them on their way out and say, bring this with you your next time in, or how do we do this? What's the practical nature?
So if I may, I was just going to say, so one of the things you could think about this is, think about when you introduce a new bit of tech, a new bit of testing equipment, or introducing a new surgical procedure. You test it out. You ask yourself, I want to do this because I think this will improve things in this way. What's the best way of starting to explore that? And you might even do it on a small scale as some kind of feasibility study. See how it works, explain to the patients that they're helping you develop the use of this, why you want to do it, help them to engage with you and what was difficult, whether they want to do it, all of those things. I think it's about having an open conversation actually about, so the piece of work I reported on feasibility was a grant funded study. It was saying, we don't know actually how best to do this. Let's test some of these assumptions.
Yeah, I think feasibility work is really important because it will eventually inspire more confidence that one is able actually to do this. But one thing I wanted to just add to a point made by Dr. Rahi in her talk is getting these measures is not a passive kind of process. You give me this data and then, and we'll look at it later. No, it's an active, it's an exploration, and it enhances your relationship with your patients because you're actually talking about things that matter. So, I can only see an upside for doing this, but I think there are real concerns about what do I do if, and that's why it's important to have a behavioral health expertise at your beck and call. Someone you can really, and it is difficult in the U.S. We're doing more and more behavioral health integration and team care of kids with complex needs, right? But we're not there yet either in terms of funding all that because we don't have, like you have, a national health system. We have a fragmented, disintegrated system of care, unfortunately. But I think we're moving better in that direction. There are ways to do it, but certainly thinking ahead to those, those kind of possibilities is really important. And starting small, trying it out, and gaining confidence. Anyway,
I think that's a great place for us to actually close up here and just thank you so much, Dr. Rahi. Thank you so much for a fabulous lecture. And Alan, I want to thank you also. The way the two of you have just led us through this topic, which those of us who take care of these kids all the time, I know it's important. And I know we don't feel we have the time. We also don't feel we have the instruments, but I think we do. I think we are there. I think we just need to work out some of the logistics, as you pointed out. And I want CGRN to help our members. Also, for those of you who haven't done our quality of life survey, Yvette, if you could be sure everybody gets that again, we'll send it out again. And certainly I want to also remind the group about other pediatric glaucoma events that are upcoming here that I think are important. We have the UK PGS, which is coming up next Saturday, actually. That is going to be a Zoom meeting as well. And then after that, that's February 5th. The next meeting that will be is the virtual meeting, also Indian Pediatric Glaucoma Society. And that looks to be pretty promising. I'm hoping that I'm hoping to see some of the quality of life things come for the providers come back from there. Nobody sees more patients than they do, as we learned when we did the International Pediatric Survey of Childhood Glaucoma with Maria Papadopoulos and Peng Ka. Our overwhelming numbers came from India. So I'm going to be very interested to hear how that impacts provider quality of life there. And I think the next slide has the little QR code if you want that, but we'll certainly be sending that out. It is something that we really don't look at. And I think it was Tanju Dada in the question and answer said, how's the quality of life for the provider impact these kids? And I think that is a big thing as well for us to look at that is ignored. But again, I also want to invite you, if you're not a CGRN member, to become one and to join us. We have grown, and this kind of collaboration is important. And I think we'll move this onto the map. You know, don't you, Jagnu? Don't you think this is going to move it onto the map? Talking about it, getting it out there. And I think through this sort of international organization, you know, providing, for example, the tools you've developed would be very helpful. And I think we'll put those on our website. This talk will be is being recorded and will be on the website. Alan's talk is on the website. And please feel free to contact us. We have some contact information for you all to go ahead and get in touch with us as you need. And if you have ideas also what you would like us to pursue, it might be interesting when we think about the cultural influence here to look at other countries that are using these tools. We'll be able to do that if you want. We could, that might be an interesting future study. We'll get Anna maybe involved, or Danielle, or, you know, some of the other people who have an interest in this as well. Please feel free to reach out to us, give us some other ideas. And finally, I do want to thank the Kolokotrones family. We couldn't have done these. The lecture series will be able to go on based on a very generous and strong support from the Kolokotrones family. And I appreciate and I'm very grateful to them for their support for education and moving forward this field. So I want to thank everybody for joining us today, and see you at the next meeting. See you then. Kolokotrones lecture coming up in probably about 4 to 6 months. Take care.
Bye.
Bye.
Bye.